My name is Mike, and I'm doing my case study over a T-spine acquired from a scoliosis series. I had a young teenage female that was scheduled to have X-rays. She was complaining that she was having lower back pain. Lately, she was complaining that sitting, standing, and walking, were uncomfortable for her, and caused pain when doing so. The patient nor her family had any history or pathology within the spine, so we ruled that out. After completion of the Scoli series, the radiologist's finding were the patient had scoliosis with mild lexoconvex thoracic spine curvature, and the trunk mildly shifted to the left, an exaggerated thoracic kyphosis, and lumbar lordosis with negative sagittal imbalance, but no findings identified to explain the pain. For this case study, I will focus more on the thoracic vertebrae due to the mild scoliosis in that region. Like mentioned, the doctor had ordered a scoliosis series, which consists of a PA and a lateral view. There's no prep for this exam other than the patient being in a gown and removing any possible artifacts that would interfere with the value of interest. The patient had to fill out a pregnancy form before beginning the exam because she was within reproductive age. The x-rays were done in room G66, which is a CR room, on a long-length cassette with the grid oriented in the portrait position. It was taken at about approximately 60-inch SID is what they prefer at the hospital. I instructed the patient to have their chest as close as they could to the IR, with feet shoulder width apart, and not to lean. And I centered the CR to the mid-sagittal plane and about the midpoint, a little above the EAM, and just a little bit below the distal symphysis pubis. I placed the gonadal shields and breast shields in position and left the collimation open per hospital protocol. Then I placed my marker in the upper left-hand corner of the cassette. This patient will be considered hypostenic in her anatomy fit on the long-length cassette. After positioning, I gave the instruction to the patient, put her arms down by her side, away from her body, take in a deep breath, let it out, and hold it while the exposure was being made. For the thoracic vertebrae, we have to have the facility's identification requirements to be visible. However, for HIPAA violations in this case study, those were all removed. The right or left marker identified on the correct side of the patient and not superimposing or covering any of the value of interest, which I placed my marker in the left-hand corner. Good radiation practices were evident, as we can see with the breast shield and the gonadal shields. Contrast resolution is adequate to demonstrate the surrounding soft tissue, bony trabecula patterns, and the cortical outlines. No quantum model or saturation is present. Scattered radiation has to be kept to a minimum, and no evidence of removable artifacts. For positioning for the thoracic vertebrae, there must be uniform brightness across the thoracic vertebrae. Spinous processes are aligned in the middle of the vertebral bodies. Distances from the vertebral column to the sternoclavicular ends and from the pedicles to the spinous processes are equal on both sides. Intervertebral disc spaces are open. Vertebral bodies are seen without distortion. The seventh vertebrae is at the center of the exposure field, but however, for the scoliosis, like I said, we have to have about 1 inch above the EAM and to the distal pubic symphysis, so we kind of centered right there in the middle. For sure, we have to have the seventh cervical vertebrae, the entire T1 to T12, and at least the first lumbar vertebrae, and 2 inches of the posterior ribs and mediastinum on each side, which we included more because we left the collimation open. And no more than 9 ribs are demonstrated above the diaphragm. The technical factors I used for this projection, the PA was taken at 85 kVp and at 16 mass, with an exposure index of 1736. For this room, the exposure index ranges from 1600 to 1800. And the technique for this radiograph was optimal for this and acceptable for this specific room. And as you can see for the anatomy, I got, and on the left side of the radiograph, you can see that we have the first rib up here on the top. We go a little bit distal, and you can see the superior heart shadow, a little covered up by the breast shield, but that's fine. That's not what we're looking for. And this is T12, and we can tell by the 12th posterior rib coming out right here. So that has to be included, and also L1 included right here. You can see the transverse processes right here on the left side, and also you can see them on the right side as well. Down here we have the left ala, or the left wing. The pubic symphysis down here, as you can see. And the spinous process of the lumbar spine right here, they're a little towards the right side. We got T1 to T12 here, right clavicle, and the superior scapula angle on this side. The errors for this, the chin was not, as you can tell, was not elevated enough to visualize the entire cervical vertebrae. But it doesn't seem to completely cover up right here C7 as needed when we evaluate for the T-spine. I would have to raise the patient's chin a little bit better to superimpose the occipital base in the mandible to get a better picture of the cervical vertebrae. This would allow a better visualization of C7. And the distances from the vertebral column to the medial ends of the clavicles are not completely equal. And they're not, as you can tell, they're not on the same transverse plane, as this one's a little bit, the left side's a little bit higher than the right side, which indicates a little bit of rotation and tilt. So to correct this, I would have to better position the patient, put the left side of their body a little bit closer to the IR, and have the patient stand up as straight as they could to get the clavicles at equal distances on the same transverse plane. And as you can see, the gonadal shield is not particularly in the middle where we need it here. So to correct that, I would need to move it just a little more medial to avoid covering any anatomy. There are no artifacts to interfere with this radiograph. And after, like I said, after the completion of the scoliosis series, the findings were there was scoliosis with mild lexoconvex thoracic curvature. The trunk mildly shifted to the left. There is mildly exaggerated thoracic kyphosis and lumbar lordosis with negative sagittal imbalance. But like I said, no findings to identify to explain the pain. Also, with the LARA kept in mind, the radiographs for the scoliosis series were suffice to get all the information we needed without repeating. So I would consider this radiograph to be suboptimal due to the errors, but once again, not needing repeating. Thank you very much.